go beyond that. And now we have come a long way in the sense that we have, mastered the art. And then now these babies do grow up and have a almost normal life. The science alone is not enough for us to actually achieve this. We need much more than that. We need the wisdom that we get. We need the kind of various organization support that we get. All these do play a role in helping these babies go to their full potential. So today I have great pleasure to welcome three great speakers, Dr. Mathulika, Dr. Anjal, and Dr. Ambika. And of course, our own dear friend, Dr. Sanjay Wazir, to moderate this session. So over to you.
Amit, shall I?
Yes, sir. If you could introduce our expert and then Dr. Kabra and then the speaker.
Yeah, a warm welcome to everyone who's joining us today on this webinar on Down syndrome. And on a special occasion of this World Down Syndrome Day, we come together now to celebrate awareness, inclusivity, and scientific advancements that shape the lives of individuals with Down syndrome. As we navigate this session, we will explore Down syndrome not just as a medical condition, but also as a journey of resilience, love, and empowerment. I have the privilege of having three esteemed guests who are going to talk about, and they're leading experts who will share their knowledge and insights into the scientific research and the best care practices that offer a holistic perspective from a fetal time to postnatal care to even the adulthood. And our the expert is Dr. Madhulika Kabra. Professor Kabra is was the former head and professor of Department of Pediatrics, and she worked in the specialty of medical genetics for almost 30 years. And I think she's among the first geneticist, and I think everybody in North India would have heard, if they've ever heard any genetic case in their own practice. And we have the first speaker, Dr. Anchal Sablok. She is a consultant fetal medicine specialist at Apollo Center for Fetal Medicine, and also in Apollo Cradle and Children's Hospital in Moti Nagar. She is also held various positions, and her achievements include being a reviewer for British Journal of Obstetrics and Gynecology, and she's an honorary international observer at Department of Fetal Medicine at NHS. Now, I would request Dr. Anchal to talk about the advances that we have, encountered in the last couple of decades as far as the management of Down syndrome cases is concerned. I'll leave it open for Anchal to take forward.
Are my slides visible? Good afternoon, everyone.
Yes, you are visible, Dr. Anchal.
Thank you. So good afternoon, everyone. I take this opportunity to talk about a very vulnerable and a very important topic, that is the antenatal screening for Down syndrome, current perspectives. It's not moving.
Ma'am, just click once in the slide and then try the keys.
Thank you. So as we all know, that Down syndrome is the most common cause of developmental delay and accounts for 15 to 30% of individuals with intellectual disability. In India, approximately 21,000 children are born with Down syndrome, and the birth prevalence is reported to vary from 1 in 1,361 to as high as 1 in 692 in various studies. So although the knowledge about Down syndrome is increasing in both the public and the private sector, we still do not have a definitive protocol for the antenatal screening of Down syndrome. So I start here with a very case that came to us recently. Mrs. X, just last month we saw her, 30-year-old Gravida 1. She was referred to us at 30 weeks period of gestation. Her first trimester screening was done elsewhere and was reported as low risk. So the history was taken by one of our fellows, and I have just written it, I've just given it the way it was taken. So the first trimester NT-NB scan as documented was absolutely normal. Double marker test was also done. We can see that beta HCG papillae were normal, and the risk for trisomy 21 was very low, 1 in 8,734. Pregnancy went ahead. Anomaly scan was done at 19 plus 3 weeks. And as we can see, where it was done, the HC had dropped to 3rd centile and AC to 2.3 centile, the femur 2.5 centile. Just to mention that in fetal medicine, what is more important are the centiles, like we see postnatally as well. We could see that there was a mild diastolic notch. So we felt that the baby is growing small. Overall, the baby is growing small because of uteroplacental insufficiency. Pregnancy further went. So keeping this in mind, pregnancy further went ahead. And she got a scan done at 27 plus 2 weeks, in which the sonologist or the radiologist found that the fetal head parameters were on the higher centile as compared to the AC and the femur. The AC was, the abdominal circumference was a 6th centile and the femur on the 7.5 centile. But the HC was on the 23rd centile. They also saw that the Likert was on a higher note. Patient wanted a second opinion. They went elsewhere, got a rescan done, where it was documented that the baby was looking absolutely normal. It was having a normal growth. Dopplers were normal. A fetal echocardiography was also done. It was also fine. Just because the first trimester screening, because the parents were very anxious, they had gone for a second opinion. The doctor there felt that the first trimester screening was done as per the non-FMF protocols. So just to rule out everything, an NIPS was done. And the NIPS came out to be high risk for trisomy 21 at 29 weeks. So they had come to us. It was a self-referral. They had come to us in view of the NIPT, which was high risk for the fetus. So we proceeded with the amniocentesis. Amniocentesis, that is the invasive testing, was done at 30 weeks, and the result came out to be abnormal. The fetus was affected with trisomy 21. Now, the parents, after a detailed genetic consult, they did not want to continue with pregnancy. And all the thanks to the Medical Termination Act 2021, a medical board was set up, and within 3 to 5 days, the pregnancy was terminated. So what do we learn from this? What all could be done and what all could be done correctly so as to not miss at least the most common chromosomal abnormalities. Now, the reason why we want to detect chromosomal abnormalities in the growing fetus is not just to terminate pregnancies, but it is also, if they would want to continue with an affected child, it is to prepare them for the future. So the antenatal screening for Down syndrome begins with the first trimester at the 11 to 14 weeks, that is the NT-NB scan. So what do we screen for? In the first trimester, as a
We can't hear you, Achal.
And it is also seen that is the reason why they need a detailed consult, they need counseling if the child has been affected with trisomy 21. It has been found that approximately 70 to 80% of these babies are born to mothers less than 35 years of age, showing that just age is not enough to screen for trisomy 21, and the screening should be universal. So how do we screen and when do we screen? We start screening in the first trimester, and the screening ideally should be done when the fetus is approximately 63 to 84 millimeters in CRL. Why? Because this increases the sensitivity and the accuracy of the ultrasound. Also, a 12 weeks for feedback.
I can't hear. Maybe something wrong on my side, or everybody
No,
cannot.
ma'am, even we can't hear.
Now we can hear you.
No.
Okay. Yes.
She's sharing again, Dr. Anchal.
So can we call Dr. Achal and see what the problem is, Dr. Debra?
Ma'am has again joined the system web now. So
Must have disconnected. Okay.
Make it full screen, Achal. Achal still can't hear. Hello? Hello?
Ma'am, she is telling that from her side, she is like it is showing as if she is sharing the entire thing and
Okay.
she is speaking. But
Yeah, we can't hear. And this is also not full screen.
yes, yes, according to her, it's full screen, but it's not taking up full screen. So there,
Maybe can we, like in some time, her system will become okay. So can we have Dr. Ambika's lecture first, and in the meanwhile, her system would start responding better? Is it so? Can we do we change or?
हाँ कर सकते हैं. We can ask her what is the problem because yeah, she logged out also and logged in again. फिर भी नहीं हुआ है ना शायद.
ma'am,
Dr.
she
Devran?
is telling that she, according from her end, it is like everything is apt, but probably there is some signal issue or something technical issue only that we are not able to see.
Amit, any problem for our end? From our end?
No, like for our end, from our end, there is no issue because I can
Yeah,
see
दिख
what
रहा है.
you all are speaking,
Hmm.
and the link is also clear because we all can see each other and hear each other.
Hmm.
So
So,
maybe
ma'am,
we can go to the next webinar, and in the meantime, Dr. Achal's system will, Dr. Devarun, if you could coordinate with her, and we can begin the next topic
I
and
think
go back to
we can go to Dr.
Ambika's
Ambika.
topic.
Yeah, no. So let me introduce Dr. Ambika. She's like DM Medical Genetics, and she has a certificate from Harvard Medical School on precision oncology, and she's a medical geneticist at Apollo Cradle Children's Hospital, and a visiting consultant at Apollo Hospitals, Ahmedabad. She would talk to us about things like the postnatal management, and of course also some of the recent advances about the management of a cognitive behavior and a cognitive outcome of babies with Down syndrome. I leave the floor open to Dr. Ambika now.
thank you, sir. Thank you for that introduction, sir. And at the outset, I would like to thank NNF, especially Amit sir and Sanjay Wazir sir, for giving me this opportunity to speak on Down syndrome on this special occasion. And I mean, for the technical purposes, I'm keeping my video off so that the slideshow goes on okay. So I hope I am visible and audible.
Yes.
Okay. So to
Yes.
start with, it's interesting to see that why do we call Down syndrome as Down syndrome? So most of us are aware, but for a common revision, it was way back in 1866 that Sir John Langdon Down, he described the symptoms, the clinical aspect of the syndrome, although it was around a century later in 1959 that Sir Lejeune was able to find out the etiology of Down syndrome, that is trisomy of chromosome number 21. Coming to certain statistics, if you look at the number of people per 100,000, the statistics of 2019, then we see that the maximum number of people, if we see according to 100,000 population, it's in UK, where 83, I mean, approximately 84 people out of 100,000 have Down syndrome. In India, this figure is low. And I was looking at this statistics, a lot of countries were given. So India is apparently very low. But when you look at the population, overall population of India, then this number would become significant. And this is not Indian statistics, but around 2/3 of antenatally detected Down syndrome are aborted in the US, which means that 1/3 are still born alive. So people, despite knowing the fact, they are opting for continuation of pregnancy, and they are okay with the child being born with Down syndrome. So this increases the responsibility of the physicians, the pediatrician, and a whole lot of gamut of multi-speciality medical people and non-medical people to bring about a change in our perspective of how we think of Down syndrome and what all can we do to actually, when the child is born, now what next? How to make that life, it's about the fulfillment of life. So everybody has that right, and it's our duty. Now, coming to the types of Down syndrome, we know that there is a free trisomy 21 in which the chromosome number 21, there are full 3 copies of chromosome 21. So this is seen in 95% of the cases. Then there are certain chromosomal translocations wherein we see that apart from the 2 normal copies of chromosome 21, there's an extra copy, but it is translocated on another chromosome. So these are usually chromosome number 13, 14, and 15. And these are like acrocentric chromosomes. So I won't be going into detail about this, but this is around 3 to 4% of the cases. Then there are mosaic Down syndrome, where we see that the child will have 2 cell lines, one which will have 3 copies of chromosome 21, and the other cell line has normal 2 copies of chromosome 21. So according to the proportion of mosaicism, the clinical manifestations may also vary. They could be mild, they could be of a higher degree depending upon the degree of mosaicism. Now, my perspective of today's talk is not to discuss exactly, how the facial features of a Down syndrome children look like, but to focus on how do we as a team, we as the medical fraternity can help in bringing about value in the life of the Down syndrome children and their families. So the first important thing that, very especially in the neonatology setup, when you are able to diagnose that, okay, this child is born with Down syndrome, or even in the antenatal setting where the parents are continuing with the pregnancy. So the first thing is breaking the news. So there could be 2 ways of doing it. I may well say that I'm sorry to tell you that your baby has Down syndrome. This means that they will have severe developmental delays, lifelong disabilities, and significant health problems. They may not be able to live independently or achieve much in life. It will be a difficult journey for your family. So it could be as pessimistic as this, or it could be as optimistic as this, that congratulations on the birth of your baby. Your child has been diagnosed with Down syndrome, which means that they may have some developmental challenges, but with the right support, love, and medical care, they can lead a happy and fulfilling life. Many individuals with Down syndrome go to school, make friends, and even work in jobs they enjoy. Excellent therapies and early interventions can help your baby reach their full potential. You are not alone in this journey. We are there to guide you and support you at each and every step. So that will bring the first important difference in the mindset of the family who was not prepared actually to have a child with Down syndrome. Now, there are certain myths which are common. Even in the medical fraternity, that, people with Down syndrome cannot work. They'll all have severe intellectual disability, and Down syndrome may be inherited. But the fact is that many hold jobs and live independently, and the intellectual disability usually varies from mild to moderate. And 95% cases of Down syndrome are de novo, which decreases the risk of recurrence to almost as the general population. Now, the first things will always remain first, whether the child has whatever syndrome you may say, be it Down syndrome or any other syndrome, is to try and establish breastfeeding, especially if the baby is term and there is, not a very significant hypotonic baby, then most of these babies should be able to breastfeed well. So that's our first prerogative, because we know that during the initial 6 months, if the baby is breastfeeding, the chances of infection and all sepsis and all decrease to a great extent. The other important thing we should not miss in Down syndrome is that they should receive vaccination, including, the pneumococcal vaccine and the H influenza, because these children are prone to infections, especially respiratory infections. So this can go a long way in preventing respiratory tract infections in these children later on. And above all is tender loving care. So I've just put this photograph. I found it yesterday. I was searching for that. This couple, Delhi-based couple, Kavita and Himanshu. So they willfully opted for adopting a child with Down syndrome, and they're happy with they had thought about it that we'll take care of a child with a disability, so they chose Down syndrome for that, and they are parents to this child. Coming to what are the problems that we as a fraternity need to address in these children so that their care can be optimized, is that yes, they have, apart from the neurodevelopmental issues, there are other issues, especially recurrent infections due to a lot of factors we will discuss later. Then heart defects, all of us know, hearing difficulties, problems with vision, oromotor issues, low muscle tone, sleep disturbances, and issues with the digestive system. And of course, then there are other factors like the genitourinary system, risk of malignancy, so on. So what I want to stress is that, rather than make the patient travel to 10 different doctors and 10 different hospitals, the best thing that we can do as a fraternity is to have more of multidisciplinary down care clinic. And that's, I feel, is the need of the hour, especially, when you have a multi-speciality setting, then all these things should definitely be made available. I'll be discussing the main aspects of what we can do and what needs to be taken care of in these babies, because no doubt they are special. The system-wise I'll be going. So coming to congenital heart defects, we know the prevalence is around 50% of these will be born. I won't be discussing the types of heart defects here. And the important thing I want to focus here is that the risk of mortality with cardiac surgery is same as in the general population. So there is no reason to, deny the right to surgery if they have Down syndrome. And on top of that, if there is a delay in correction of large shunt lesions, they can cause exacerbation or more severe pulmonary vascular disease. Now, seeing the inherent anatomy of the Down syndrome children, certain perioperative concerns need to be taken care of. And this I've put because, the child may come to you after he's been operated or before he's operated. He might need ICU care. So you need to take care of certain points. These include that this child may have subglottic stenosis, there is macroglossia, there is hypotonia. So this will cause you an increase in the difficulty in intubation as well as extubation. Moreover, these children have a risk of chronic pulmonary infections. There is risk of aspiration and laryngospasm, and there is strong tracheobronchomalacia as well. So extubation has to be also done very carefully. Pulmonary hypertension there is a definite risk of this, and this can lead to post-operative pulmonary hypertensive crisis if not detected and treated early. Then there is an increased risk of arrhythmias, including bradyarrhythmias and heart block, as compared to the normal children. Hypotonia and delayed neurological recovery may prolong ICU stays in these children. There is a slightly increased risk of seizures as well. And because there is some degree of immune dysfunction, there is a higher risk of sternal wound infections in these children. So meticulous prevention of infections is equally important. Coming to the growth potential, their final height as compared to the age-matched normal population would be less by 2 to 3 standard deviations, and head circumference will also be on the lower side, although it won't be, frank microcephaly. Growth is more compromised if there are major congenital heart diseases or associated comorbidities like celiac disease or genitourinary malformations. But what we can do to optimize the growth of these children is regular growth monitoring. And in this case, you can use specific Down syndrome growth charts. So I'll just make a reference of this. So this work was done in PGI Chandigarh. Initially in 2021, this group had come up with BMI-based charts for the Down syndrome children. And recently, I couldn't get the full article, these growth charts for weight and height also. So that was for BMI in 2021. In 2024, they have come up with the weight and height growth chart for Indian children with Down syndrome. So I guess in future, we might be able to use them. Then thyroid screening and management has to be done early. Balanced diet and exercise. So diet is also a very important aspect which we often tend to miss out. Then addressing sleep apnea early is important. And growth hormone will not be helpful in increasing the height of these children. Coming to the most commonly talked about, the neurodevelopmental issues. So it's important to learn that the IQ of these children will range from 30 to 70. They will not have profound intellectual disability. So it's usually mild to moderate. So this message needs to go deep, because sometimes we as physicians also think that, okay, iska kuch nahi ho sakta, isko Down syndrome hai. There is no point in, seeing this child in detail and all those things, especially when you have a busy and large OPD. So that empathy has to come in. DQ is usually lower in infancy, but then gradually it can increase. Social quotient is higher than their IQ or DQ, which means they are really lovable and cute children. However, ADHD may be there in as high as 50% of the children, and autism spectrum disorder is also common in up to 16% of children. Coming to the developmental milestones, the important thing for us is that these children respond well to physiotherapy. I mean, the age, a normal child starts walking at 2 years, they may start walking at 1 year, they may start walking at 2 years. And cognition-wise, they can learn with structured support, visual learning preference. So it has to be a structured approach. So that is what the main thing is. We may not directly be able to render this, but then to find out ways how this particular family can reach to the appropriate place where this thing will be available to them. So that's our duty. Socially and emotionally, they are warm, affectionate, strong. And adaptive skills, they can achieve independence in daily activities with training. The important point here is need for structured teaching. So that has to start early. Language and communication, the most important aspect is that they can understand things. Their receptive skill is good, but because of their oromotor discoordination and hypotonia, they are not able to express themselves the way they would want to. And additionally, they have difficulty with grammar and sentence structure. Some degree of social and communication difficulties, which to a large extent can be taken care of if proper training is available. So nowadays we have certain aids like picture exchange communication system, where the baby or the child, through pictures, he can communicate a particular thing that he wants to convey to the caregiver. Then there are augmentative and alternative communication methods. So emphasis can be made on them because this will be an early stimulation for them through these, and then it will help develop their skills in these particular areas where they are weak, the expressive skills. In the gastrointestinal issues, they could be functional and structural. Functional is like, you will mostly find this, these children suffer from constipation, toddler diarrhea, some form of GER may be there in especially in the early phases. And other than this, the structural malformations, there is an increased incidence of celiac disease, 5% in these patients. And what the recommendations, the IAP recommendations for management of Down syndrome say is that physical examination in infancy should include inspection of the perineum for anal patency, specifically to look for structural malformations, and growth monitoring, specifically on the Down syndrome growth charts, as a screen for malabsorption. So if it's like faltering, going down the centiles or the standard deviations, then one should screen for celiac disease. Coming to hypothyroidism, these children may have congenital hypothyroidism, 1 to 2%, and around 25-30% will have acquired hypothyroidism. Hyperthyroidism can also be there, but that's very, very rare, and it happens at a later stage, I mean late adolescence or adulthood. Now, the recommendations say that apart from the usual newborn screening, we should repeat that thyroid screen at 6 months, and then like every year we have to do it once. And for subclinical hypothyroidism, so a large number of children will have a high TSH but a normal T4 value. So these are subclinical cases. They need to be treated only if there is a persistence of the TSH value above 10 MIU per ml, or if there is thyroid autoantibodies or the child is symptomatic. Hearing loss and ENT issues. So we have to keep in mind that the child can have both the conductive hearing loss as well as sensory neural hearing loss. In the early childhood, it is more of conductive hearing loss, and this needs to be corrected early because these children, as it is, they have speech delay. So if this hearing component is not taken care of early, either through the use of ear tubes, grommets, or any other mechanism, then it is going to be detrimental for their overall development. For the SNHL, cochlear implants have shown a good result in these children. Apart from that, if you come to the screening protocol, then it has to be done at the time of birth, and then again between 6 and 10 months, then annually till 5 years. After that, you can decrease the frequency to every 2 years. 50% of children with Down syndrome will have refractive issues by 4 years of age. So there is screening for that as well is important. First eye examination at 4 to 6 weeks. So when they come for immunization, you can combine this with an eye examination. Thereafter, as needed, and then at 2 years, 4 years, and after that, every year. Coming to the musculoskeletal issues, we know that the most important thing that we are looking for is atlantoaxial instability. So that's not very common, and usually you don't need to do a cervical X-ray in these children. But if you see that there's a difference in gait, there is spasticity, or any other sudden abnormality is noted, which is suggestive of cervical cord compression, then you should definitely look for it. And if the child wants to play contact sports. For the flat feet, there are orthoses which are available and they do work well. And parents have found it useful to use these orthoses for flat feet. Pubertal issues, it's important to know that puberty, though there is a type of hypergonadotropic hypogonadism, but still the puberty occurs on time and progresses at a typical rate. These individuals have intimacy needs and sexual feelings as in other children. So this is also very important. Men with Down syndrome are usually infertile, but females may be fertile as high as 70%. And if a female wants to give birth to a child, then there's a 50% chance of the child having Down syndrome. So contraceptive advice should be provided. So this was an Indian couple. So both of them have Down syndrome and they got married. So that's a testimony to what I have just said. Coming to the risk of recurrence, we know that for the 95% of the cases, the risk of recurrence will be less than 1%. Those which have translocation Down syndrome, there the recurrence risk depends upon whether the mother is carrying a translocation as a balanced carrier or the father. If the mother is carrying, then the recurrence is high as 10 to 15%. If the father is a carrier, it's low, 1 to 3%. Okay. The interest of time, I'll just skip this. Nothing very prominent in this. Health checkup. So this is from the parent information booklet by the Indian Academy of Pediatrics for which is common both to the physician and to the children basically. So when all they need to come for the growth evaluation, eye, hearing, and so on and so forth. So you can go through this. Coming to the malignancy in Down syndrome. So there is an entity called as transient abnormal myelopoiesis, which occurs in 5 to 10% of Down syndrome newborns. It resolves spontaneously in 20%, but unfortunately 20% may progress to myeloid leukemia. So there are specific diagnostic features for this. Clinically, they have hepatosplenomegaly, jaundice, coagulopathy. And usually it resolves with supportive care unless until the WBC count is very, very high. Then they might need treatment with cytotoxic cytarabine. And the risk of both AML and ALL is higher in these children, as high as the tune of 500 for AML and 20 for ALL. The good thing is they respond well to chemotherapy. And another good thing is that the incidence of solid tumors is less in this particular group of children. Coming to the role of patient support groups, which is probably as important as giving them medical care, is that their emotional needs, their information, rights to education, employment, and healthcare. So all this is taken care of. I mean, we can't take care, we as medical people can't take care of all this. So for this, there is the role of patient and parent support groups. They guide families on early intervention and celebrate their abilities and achievements, which has a positive impact on their mental well-being. In India, we have this Down Syndrome Federation, and these are the locations where all over India, their branches are there. They have in Delhi. I'm not sure if they have a branch in Meerut, but we can work on that. Yes. So no diagnosis beats passion and talent. So we know that there are two movies now on Down syndrome. One is this Arhan. This was in Hindi, and this particular actor is actually having Down syndrome. There is another one. This was a Tamil movie or some South Indian movie where this Gopi Krishnan, he's the actual protagonist of the movie, and this one also has Down syndrome. So this is a Bengali singer, a child with Down syndrome who has been lauded by, national awards for his talent in singing. Then there are international personalities, Karen Gaffney, who crossed the English Channel. Then there is this model, Madeline Stewart from Australia. From Europe, we have Pablo Pineda, who was the first European with Down syndrome to get a college degree. So a label of a Down syndrome, a physical or a mental disability does not actually stop you completely from pursuing your passion and showing your talent. So what I mean to say is that if we are positive, we can give that positivity to the family, and then we can have a positive outcome for these children to the tune of their optimum capacity. Thank you. And if there are any questions, we can take later. So there was a lot to discuss. I have just put it in short.
I think we can go back to the first speaker and then finish the talk.
We can have Dr. Madhulika ma'am as expert comments on this talk. That will be invaluable.
Take that later also, but then what I would like to say is that first of all, thank you very much for inviting me for this session. And just for everybody's information, and I would like to greet everyone for this Down Syndrome Day. The theme, every year they have a different theme for Down Syndrome Day. So this year the theme is improve our support system. So that we can be inclusive for supporting these patients for care, education, and opportunities. So Ambika gave an excellent talk, and her messages are very clear that these patients should be inclusive and they can do a lot. And maybe there are some specific questions later on. Maybe after the first talk, we can discuss those, if that's okay, Amit.
Yes, ma'am, that is fine. Okay, fine. So we can go to Dr. Achal's talk again. Dr. Debarun, if you could share from your...
Thank you so much. Can we just put it on the big screen?
Fine now.
Thank you so much, and thank you, Dr. Amit, for helping me out. So I was talking about the antenatal screening of Down syndrome. So I think we've already discussed this, that the published data suggests that in India, approximately 21,000 children are born every year with Down syndrome. And there is a very high birth prevalence, which varies around 1 in 1,361 to 1 in 692 in various studies. Next slide. So yes, so although the knowledge about screening for Down syndrome is increasing day by day, still in India, both in the public and the private sector, we do not have a definitive protocol to screen for Down syndrome. Next slide. So I start here with describing a very interesting case which we saw just last month. Mrs. X, 30-year-old, Gravida 1, she was referred to us at 30 weeks period of gestation. Her first trimester screening was done elsewhere, which was low risk for chromosomal abnormalities. Next. So as we can see, so this history was basically taken by one of our fellows. So I have just given it the way it was taken. The NT&B scan was done elsewhere, which was documented to be absolutely normal. Next. Double marker test was also done. And as we can see, the risk for trisomy 21 on combining the double marker test and the NT&B scan was very low, 1 in 8,734. Next slide. So because everything was normal, the pregnancy continued further, and she got an anomaly scan done at 19 plus 3 weeks, in which there was no obvious gross congenital abnormality. But as we can see, the head circumference had dropped to 3rd centile, and so as the abdominal circumference and the femur was found to be 2.5th centile. So we also as fetal medicine experts are more concerned about the centiles rather than the absolute numbers. Now, there was a mild diastolic notching that was seen in the uterine artery. Because the first trimester screening was documented to be low risk, we thought that the baby overall is growing small because of the uteroplacental insufficiency. So she got a neck scan done. Next slide. Next, please. Yes, so she got a neck scan done at 27 plus 2 weeks. And as we can see, the HC was on the 23rd centile, but the AC was on the 6th centile and the femur was 7.5 centile. Overall, the baby was growing small. There was a bit of uteroplacental insufficiency. The umbilical artery Doppler were documented to be high. So it was thought that the baby is now growing on the leaner side because of this. Still they wanted a second opinion. So they got a scan done from a fetal medicine expert. Next, please. And at 27 plus 2 weeks, a second opinion was taken. Everything was documented as normal, normal anatomy, normal growth. The AFI was 18.7 centimeters, and even a fetal echocardiography was done, which was normal. But the doctor felt that because the first trimester screening was not adequate, it was not as per the FMF protocol, and the patients were very anxious. And elsewhere, it was documented that the AC, there are discrepancies between the HC and the AC. Just to put everything at rest and just to ease out the anxiousness of the couple, an NIPS was documented. It was advised. So the couple got NIPS done at 29 weeks. The report came, and the report came out to be high risk for trisomy 21. Next, please. So this was a self-referral. They had come to us with NIPT, which was high risk for the fetus being affected by trisomy 21. We did an amniocentesis at 30 weeks, and the report came out to be positive for trisomy 21. Next slide. Next, please. Now, all the thanks to the MTP Amendment Act of 2021, the medical board, the parents did not want to continue with pregnancy. We had called for a medical board, and within 3 days, this pregnancy was terminated. Next slide. So what do we learn from this? We learn the importance of the appropriate screening for fetal aneuploidies, what should be done correctly so as to not miss out at least on the most common chromosomal abnormality, that is trisomy 21. So what all could have been done so as to diagnose this previously and not take the pregnancy till 29 weeks and the patients and the parents coming out with this kind of a report. So screening for fetal aneuploidies, next slide, begins at as early as in the first trimester, that is the 11 to 14 weeks. And what do we screen for? We screen for the most common chromosomal anomaly, that is trisomy 21. And we also look for other common aneuploidies. Since 1990, there has been a tremendous advancement in the screening for common chromosomal abnormalities. Next slide. So we see that these babies with trisomy 21, they live a long life. So the screening for trisomy 21 antenatally doesn't take place just to put the pregnancy, to terminate the pregnancy. It is also to counsel the parents and to prepare them for the future ahead, if they would want to continue with these pregnancies. Because nowadays we see a lot of patients and a lot of couple with 40 years of age, IVF conception, who would actually want to continue. So there sometimes they are just okay with this baby. So we have seen that 80% of the babies with trisomy 21, they are born with mothers less than 35 years of age. Next slide. So we see that just screening on the basis of age is not enough. So that means the screening should be universal. Next slide. When do we screen? So ideally speaking, the first trimester screening should take place when the fetus is at least 63 to 84 millimeters in length. And why? Because this increases the sensitivity of the ultrasound. Next slide. Also, in the past years, it has been seen that the 12 weeks is not just the 12 weeks ultrasound is not just to screen for trisomy 21 or for Edwards or for Patau. It is also to screen for other abnormalities, screen for small for gestational age babies and other conditions such as preeclampsia, preterm delivery, and prediction of complication in twins. Next slide. So how do we screen for common aneuploidies? In the first trimester, we do something which is called as a biochemical screening, that is the double marker test, and which is combined with the NT-NB scan. Next slide. Next slide. So the NT-NB scan has major ultrasound parameters, and what we look for is a nuchal translucency, the nasal bone, ductus venosus, and tricuspid regurgitation. Next slide. So nuchal translucency, what is it? It is basically just an anechoic strip. It is the fluid behind the back of the neck. And it has been seen that the abnormalities are proportional to the thickness of nuchal translucency. Next slide. What is more important is not just to measure nuchal translucency, but to measure it properly so that we have the absolute values. And if we do the scan as per the FMF protocol, we see the nuchal translucency, the nasal bone, the ductus venosus, the tricuspid regurgitation properly, probably this case would not have been missed in the first trimester. So the FMF gives out certain guidelines so as to how the nuchal translucency should be measured. Next slide. So the fetus should be in the neutral position. It should be a mid-sagittal view. The cord around the neck should be seen, and the maximum length of the maximum thickness of the nuchal translucency is measured. Next slide. And the NT is measured properly, and it should be measured as per the protocol. So these guidelines are freely available across the internet. Next slide. So whenever, as a fetal medicine expert, a patient comes to us, so for us, the patient is the fetal patient. So whenever a patient comes to us, we always look back at the imaging quality. We look back at how the images has been taken. And all these images are bad technique images. And this is the reason why probably this case was missed in the first trimester. Next slide. So it has also been seen that NT increases with the gestational age. The fluid behind the neck, it increases with the gestational age. So it is not that the value is important. It was the old standard when we used to take the 3 millimeters as the cutoff. No. Next slide. What is more important is that at which centile the NT is falling around. And if the NT is more than the 95th, 99th centile, it calls for invasive testing. Next slide. So increased nuchal translucency, the thickness behind the back of the neck, it increases and it is proportional to the number of structural abnormalities as well as chromosomal abnormalities. Next slide. So this paper, this image was published 20 years back by Nicolaides, and it has been clearly seen, as all of you can see, that maternal age, just by taking the maternal age into consideration, the detection rate of trisomy 21 is 30%. And when we combine it with the NT, the detection rate increases to 70 to 80%. And when the NT maternal age is combined with the biochemical screening, the detection rate goes to 85 to 90%. Next slide. So increased NT can also be associated with a number of structural abnormalities. So as we are all aware now that a first trimester scan is also called as a mini anomaly scan. We can look as many fetal abnormalities and detect them as early as in the first trimester. Next slide. The next comes the evaluation of the nasal bone. So again, the nasal bone evaluation should be very materialistically should be done. The fetus again should be in the neutral position, mid-sagittal plane. And as you can see, the second line is the nasal bone. The first line, the equal, this is what we call as the equal to sign. And the first is the skin covering the nasal bone, and ahead is a nasal tip. So the nasal bone should be more echogenic as compared to the skin covering it for us to say that the nasal bone is present. Next slide. So again, there are papers available, guidelines available as to how the nasal bone should be correctly evaluated. Next slide. Next slide. So again, now in the recent years, we have also incorporated, next slide, the tricuspid regurgitation Next slide. And the evaluation of ductus venosus Dopplers, and we combine them with the other parameters. Next slide. Next slide. So when we are coming upon to the combined first trimester screening for trisomy 21 or for common aneuploidies, we put in the values of the biochemical test. Next slide. Along with the parameters, that is the NT, DV, nasal bone, tricuspid regurgitation, and we see how the risks are coming. Next slide. And this is how we compute the risk. So the background risk is basically the age-related risk, and the adjusted risk is the combined first trimester screening. Again, saying these are just numbers, and the most important thing is that the parameters should be evaluated properly so as to not at least miss out on the most common aneuploidies. Next slide. So as we can see that the combined test is nothing but the maternal age plus the NT and the biochemical test, when combined with nasal bone, tricuspid regurgitation, or the ductus venosus Dopplers, properly when taken, increases the detection rate to approximately 96% with a false positive rate of 2.5%. So, but still we can see that there will be a 4% lag to diagnose common aneuploidies, most common being trisomy 21. Next slide. Now, in the recent years, in the past few years, previously we were doing in the biochemical screening PAPA and beta HCG. Now we have also started incorporating PLGF and the alpha fetoprotein, and this is called as a first trimester quadruple test. Alone, it gives a sensitivity of approximately 80%, and when combined with nuchal translucency, the detection rate goes up to 95%. Next slide. So, this slide is basically showing us that after we have done a first trimester combined screening, we do something which is called as a contingent screening. Now, because we see the baby, we evaluate all the parameters as per the FMF protocols. For us, the high risk is the one which is greater than 1 in 150. If the patient falls in this category, we offer invasive testing. In the intermediate category, we offered something which is called as a non-invasive prenatal screening. If the fetus falls in the low risk category, routine care is offered. So this is called as a contingent screening. Next slide. Now, when the pregnancy goes ahead, we come across the anomaly scan. In the anomaly scan, again, we look for markers for trisomy 21. And these markers are called as the soft markers for trisomy 21, telling you and minding that these are not structural abnormalities. These are just soft markers. So there was a meta-analysis which was published by Agatha Collis and his colleagues in 2013. Next slide. In which he documented that there are 9 soft markers which should be seen properly in the anomaly scan, and he had given the likelihood ratio of each isolated soft marker, maximum being of the absent or the hypoplastic nasal bone. That is, if alone we come across a fetus in the anomaly scan, if the baby has not got the nasal bone ossified, as compared to the primary risk, the trisomy 21 risk is going to increase by 6 times, 6-fold it is going to increase. Next slide. In 2021, the Society of Maternal Fetal Medicine Consult series, they came out, next slide, with a management of these 9 soft markers when the sonologist come across it. And very nicely it is given what and how things should be managed. Next slide. So coming upon to the biochemical screening, like in the first trimester, we get the double marker test, we combine it with the NT-NB. Similarly, in the second trimester, we have an anomaly scan, we look for the 9 markers, soft markers of trisomy 21, and we can combine it with the biochemical screening, which in the second trimester is called as a quadruple screening. Now, previously, there used to be things that triple test also used to be done. That was also a biochemical screening. But this paper was published in 2021, in which we have clearly shown that quadruple test has a higher superiority as compared to the triple marker test, and triple marker test should now be obsolete. Next slide. Now coming upon to what should be done. So this question was first raised in 2005. That should we do a first trimester screening? Should we do a second trimester screening? Or should we do both? Next slide. So When we come across to the first trimester combined screening, we know that the detection rate can be as high as 95 to 96% when the parameters are taken properly. Similarly, in the second trimester, we look for the markers and we get the quadruple test done. If we combine the second trimester and we integrate it with the first trimester, that is the anomaly scan, the quadruple test, and we combine it with the first trimester also, this is called as the integrated screening. Next slide. So before the advent of the non-invasive prenatal testing, thing which should be done, or which was basically done, was the integrated screening to increase the detection rate of trisomy 21 approximately to 90%. Now, after the invention of non-invasive prenatal testing after 2015, things have taken a major turn. So what is non-invasive prenatal testing or non-invasive prenatal screening? Minding again, this is a screening test. All these tests are screening tests and none of them is a diagnostic test. Whenever a test comes out to be high risk, the patient should be offered invasive testing, which remains the 100% diagnostic test. So non-invasive prenatal screening is that the fetus in utero has cells, has DNA, and this cell-free fetal DNA comes in the maternal blood. So if we take the maternal blood and if we test for the cell-free fetal DNA, we are looking at the chromosome directly, which gives a sensitivity for common aneuploidies as high as more than 99%. Next slide. Now, there have been papers to see that because we are having cell-free fetal DNA, so can other things be also detected, like the copy number variations or the genomic testing? So this is still under review, and this requires another, basically a CME. Next slide. So coming upon to contingent screening, if the parents cannot afford NIPS, the integrated screening remains the most comprehensive pregnancy management for antenatal screening of Down syndrome. Next slide. And patients who are high risk or intermediate risk for trisomy 21 on integrated screening, or going back to the first trimester combined screening coming in the high risk category, non-invasive prenatal screening can be offered. Now, this non-invasive prenatal screening has a sensitivity for trisomy 21 to approximately 99.5%. Now, what does this mean? This basically means that out of 100, it is going to miss 0.5. That means if there are 100 negative reports, 0.5 will be missed, which means that out of 200, 1 will be missed, which means that out of 1,000, 5 babies with trisomy 21 will be missed by NIPS. So this still remains a screening test and not a diagnostic test. Next slide. Still, coming upon to further, in 2023, ACMG had given the practice guidelines to what is the best screening test for trisomy 21. And it stated very clearly, next slide, that because NIPS can be done anytime during gestation more than 10 weeks, only one lab test is required. It has a very high sensitivity for the most common aneuploidy. Next slide. So it should be offered to all patients with singleton pregnancies for common aneuploidies. Next slide. And it should be offered to even in twin pregnancies for the screening of trisomy 21. If the patient, so even in our setup, we do a first trimester scan, we do an NTNB scan, we look for the parameters of Down syndrome, the soft markers. We also look for other structural abnormalities. We do a complete anomaly scan of the baby. And to all pregnant women, irrespective of the age, we do offer them NIPS. If they cannot, that's another method, but we do offer it. Next slide. So it basically clearly says that all patients should be recommended the availability of NIPS, and the pre and postnatal counseling should be accessible to all pregnant female irrespective of the age. Next slide. So this basically gives us the sensitivity and detection rate of several tests. Next slide. Thank you.
Yeah, thank you, Thank you, Dr. Anchal. Finally, we could,
Yeah, thank you so much, sir. I hope I just could make the best of my time. This was a very, very broad topic, and I just tried my level best to cover as much as possible and just to make things clear as much as possible.
Yeah, since this is largely a group of pediatricians and neonatologists, what is one single advice that you would want to give it to people in the group, that when should and they motivate the people to go for a newborn screen, sorry, the antenatal screening, because for obstetricians, for most of them the things are clear, but pediatricians also need to motivate because they see the parents who come for the second pregnancy. So at least, and since the mother is already in the advanced stage, and of course we know, okay, advanced age is not the only criteria for the Downs, but what is one single message that you want to give to pediatricians?
So screening for Down syndrome, or for that matter, common aneuploidies, should be available to all. Every pregnant female, irrespective of the age or the gestational age, should be motivated to get the screening done. Screening should start as early as in the first trimester. A proper NT&B scan should be done. If possible, now we are also getting it done the first trimester quadruple screening. We offer NIPS to all. Those who can get it done, well and fine. Those who could not, we do screening again at the anomaly scan. We look for the markers and we integrate it with the first trimester to see how much is the risk we are getting. If we feel that the patient needs any further testing, we again offer or motivate them to get an NIPS. So we are basically following the protocols, we are basically following the guidelines.
No, Ambika.
How early can NIPT be done? How earliest time when NIPT can be done? And
yes, so NIPS can be done after 10 weeks period of gestation, and it can be done till any period of gestation. Now, because again, the case that I presented, it was like, it was scary for the parents. It was scary for us also. Patient coming at 30 weeks with NIPS report coming out to be positive. Now, because the MTP Act has changed, I'm just saying this aloud, but again, the screening is not for termination of pregnancy. It is to guide them. It is to prepare them for what is there in future. So NIPS again can be done till any period of gestation, starting from 10 weeks.
Starting from 10.
Yes. And invasive testing now also can be done at any period of gestation. In our center, we are doing invasive testing as the pregnancy, even in 35, 36 weeks. If we feel, because we are not just screening for Down syndrome, we screen for other syndromes as well. So we are doing invasive testing even in advanced pregnancies as well.
And how early can invasive testing be done? And difference between invasive and screening sensitivity of NIPS and invasive tests?
So yes, sir. So basically, sir, NIPS, these are all screening tests. So screening means we just want to make sure that everything is looking okay. The sensitivity of NIPS is 99.5%. And as I stated that 99.5%, what does it mean? It means that if we are having 100 negative reports, 0.5 will be missed, which means out of 1,000 negative report, 5 Down syndrome babies will be missed by NIPS. And that is the importance why we are not just relying on NIPS. If we feel there is a need, if we are seeing a chromosomal or for that matter, a genetic syndrome on the scan, we do offer invasive testing. And invasive testing is, it is divided into 2 categories. One is the CVS, that is a chorionic villus sampling, which is done in the first trimester, in which we take the placental tissue and we send it for testing. Whereas the amniocentesis is done after 16 weeks period of gestation, in which take out the amniotic fluid and we send it for genetical testing.
So can I make a comment here, Amit?
Yes, ma'am. Yes, ma'am.
So thank you very much, Aanchal. It was a very nice presentation. So one thing is that though as per the recommendations, NIPS has been said that it should be offered to all antenatal mothers, irrespective of their risk. But as of now, we do not recommend NIPS to everybody, though it can be offered and it can be told to them. And most of the time, what most people do now is that if we can catch them in the first trimester, and as Achal said, that first trimester screening, if we do NT-NB along with biochemical markers, the combined screening sensitivity is very high. And what we usually do is, though NIPS is said to be, can be done as early as 10 weeks, but what we usually do is that we do not do it without doing a NT-NB scan, which is usually done earliest between 11 to say 13 plus 6 weeks. And the reason for that is that if you find anything abnormal, as Achal said, many other things can be picked up in that particular scan. And then if there is something abnormal, instead of doing NIPS, we may have to go on to
Correct.
invasive testing directly. So that is also one thing which I think we need to keep in mind, that because of the very nice first trimester ultrasounds available now, maybe there is a need for invasive testing for something else also if we get some abnormality. So with the ultrasound scan, NT-NB scan, and then obviously we can decide whether we need to go invasive or NIPS is a good option. So this is one thing which I would like to emphasize here. And I think first trimester scan, which was being missed earlier in many of our pregnancies, still is happening. If it can be done in the first trimester, it's a great thing. And Achal said that we pick up many more abnormalities in the first trimester scan as was being done earlier. Are there any other questions in the?
None, but Dr. Anchal, what are the biggest gaps in early medical intervention and support for children, specifically in India, Down syndrome? What changes do you recommend that we should probably, or we need to advocate for making, because we know, okay, the rural system, for example, is very fragmented. The referral system is very fragmented. There is the government support therapy centers are, especially in rural areas, do not exist. So when we are talking of urban, infrastructure, how do we make it a reality for the whole country?
So this is for Ambika or for Achal?
Maybe you can take it, ma'am.
No, Ambika, you can, because you talked about the care of children with Down syndrome problem.
Yes, ma'am. So thank you for that question, sir. Sir, the first thing I personally feel from my experience also is that if we talk about the urban setting, let's start from there. We have to have the urban setting in place, then we can extrapolate it to the rural setting. So coming to that point, at least at the specialty level, if we talk about pediatricians who are taking this delivery and other things, who are able to at least make a facial diagnosis of Down syndrome, then the most important thing is to understand and be convinced we need to have that conviction first that, this is not a hopeless case. We have to do something for this child. And then there are every city system, there are it's a tree basically, so you can always go higher up. So if you do not have those resources where you can straight away do something for the child, then at least a positive counseling and to direct them to a center where such type of children are being taken care of. So that can be done at the primary physician's level. That is what I feel should be there, because otherwise they'll be running here and there and they lose that time and their resources, their money, their energy, and that negative thing, if it sets in, then that's the worst thing that can happen. So that is what I feel is the most important first step. And then ma'am can add to it.
So I would
yes, yeah,
to-
please, Achal, yes.
So, ma'am, I would also like to add that, whenever the patient, they come across a trisomy 21 baby, they are like shattered. So counseling is very, very, very important. That, see, it is like a syndrome. There has to be spectrums of the syndrome. And as every individual is different, it is not necessary that a trisomy 21 child is going to have a very bad intellectual,
Outcomes.
IQ level. So it's a syndrome, and therapies, there's so many things which can be advocated, and right approach at the right time really, really goes a very long way.
Yeah, definitely. So I agree with both of you, Ambika and Achal. So I think counseling skills have to be very, very appropriate. So it just reminds me of a patient who was seen in our hospital only in one of the OPDs, and he came with a diagnosis of Down syndrome. And the first thing the resident told the family that they are at increased risk of having leukemias. So that is the message they had in mind when they came to us, and which is a very, very low risk actually. So counseling has to be very, very appropriate and positive, but has to be balanced, right? We should not be over optimistic about things, but we should not be pessimistic about things. And because most of these children will do very well. So what Ambika said is very, is very pertinent. But one thing which I would say is that as a pediatrician, I think there is nothing very specific or which cannot be done in a middle level hospital or even a clinic. So once the diagnosis is made, maybe for initial counseling and the initial workup and maybe the chromosomes, etc., the patient can be referred. And there are very clear guidelines of managing these patients, as Ambika has shown. So as a pediatrician, I think we can manage these children very well. And the multidisciplinary approach is extremely important. And almost all of them would need initially a 6-monthly follow-up and then a 1-yearly follow-up. And there are very clear guidelines what is to be done and referrals accordingly. So, all Down syndrome children need not be referred to geneticists all the time. Maybe initially for counseling and obviously for prenatal testing, they have to be referred. And then they can be easily managed by a pediatrician. That's what my idea is. And that's why probably this webinar has also been planned, so that the pediatricians are also confident in managing babies with Down syndrome.
Another thing, ma'am, I feel is important to have some sort of registry, in the sense that we are taking note of these patients being born, and what like that way we can plan out their management plans, and we can see it over a period of time. What was the lag? Where could we have done better? So
Right.
that is one thing I feel should be there.
Yeah. So I'm not aware if there are any Down syndrome registries in India. I may be wrong, but most of us now there are several places where we have clinics, and as you know, we have a separate Down syndrome clinic also. So if data can be collated, I think it would be a good idea to have it all at one place, because again, as you emphasized, the phenotypic spectrum is very, very heterogeneous, right? So that will definitely be important to have.
Can NNF do something in this regard, ma'am? Members of NNF and IAP, if for this could be the message for the leadership, okay, if we go in this direction and we have a concerted group who becomes an advocate for Down syndrome in NNF, and then we can move forward in some manner.
Definitely. See, you already have IAP guidelines for management of Down syndrome. It is
Yes,
there.
ma'am.
And then I think similarly, you can have small sessions like this, maybe more webinars, because it is very common. Down syndrome is very common, and everybody will get a chance to see these babies. So maybe one about major counseling points, right? The kind of counseling which is required and which babies need referral. And for antenatal counseling, when to refer and what can be the investigation. So I think something like this can be planned by the IAP or NNF. It can be done. Another thing which I would like to emphasize here, that many of our states have the RBSK facilities, Rashtriya Bal Swasthya Karyakram. And then they have very nice early intervention centers. So if in a particular place where the patient belongs to, for intervention, physiotherapy, etc., they can be referred to that place also. Because if you see, even at tertiary care centers, you may not have everything at one place. Like even the multidisciplinary care patient has to go to multiple places. Whereas this early intervention centers of RBSK, they have physiotherapy, they have hearing assessment, they have early intervention by stimulation, everything at one place. So these can really help. And in fact, they also have guidelines for management of Down syndrome, the RBSK team.
Amit, one of the things that you probably can do is like to start a registry, at Ambika was saying, because once we have India is a large country with so many Downs being who are being born now. So you would probably have a lot of images from patients, and you could use it for an artificial intelligence and machine learning for rural settings to even take a picture and say, okay, this is the kind of
Yeah.
a type. So I mean, if one lead that you could probably take, this is one of the things. Creating a registry would be a good idea.
Dr.
Yes.
Sanjay, there are 2 questions in the chat box.
Uh,
In the QA, in the QA.
Okay, yes. So a lot of Down syndrome cases are being diagnosed by RBSK team, but there is no system of registration for which we are not able to capture the data for a follow-up.
Yeah.
I think so. I think ma'am has already discussed that.
Yeah. So RBSK has a referral system, but they have a referral system for more critical issues like congenital heart disease. They have a referral system where to go. I'm not sure if they really have a referral system for referring Down syndrome patients. There are other 2 questions also, Dr. Sanjay, if you can see. One is the resource limited settings for high risk women. Can we minimize the test? If so, what can be done? Actually, you want to answer that?
Yes, ma'am. So, ma'am, basically, there has to be proper training of the NT-NB scan because it remains the most important ultrasound.
Yes.
And just not the Down syndrome, because a high NT can guide us to a lot many syndromes, you know. So
Yeah.
the training has to be proper. So right now we are having OPUS training, you know, where you do not have to have live patients demonstrations. There is OPUS, there are so many things. Again, artificial intelligence is coming, but training has to be appropriate.
Yeah, so training in, see, minimum, as I said, first trimester scan, if it can be done along with a biochemical screening, the detection rates are quite good. So even if that can be done and the high risk mothers like previous history, advanced age or abnormal ultrasound, then they can be referred for, say, invasive testing or NIPS. Yes.
Yes.
And another question is cell-free fetal DNA being done? So yes, it is available. Many laboratories are offering that.
So, ma'am, this I would just like to emphasize that nowadays many labs are doing the basics. So, cell-free fetal DNA is also being done of various types. You know, there is an advanced, there is an extended NIPS, and then there is a basic NIPS.
Right.
So, what of is that right now many labs are doing a basic NIPS for as good as 5,000 to 6,000 as well. So it's not very, very expensive now.
Yes, right. And the sensitivity of basic screening, which Aanchal means 21, 13, 18, and the sex chromosomes, that is usually in that the reliability of that is much more as compared to other microdeletion syndrome. So we usually do not opt for extended screening.
I think there are no more questions now. Amit, do you have the final word?
Yes, so I think we can close the session with thanking our expert, our teacher, our guide, mentor, Professor Madhulika Kabra ma'am, and congratulating her as well for just retiring from as a head of the Department of Pediatrics at AIMS, New Delhi. So, ma'am, can you answer us? All the audience can know where are you placed now after retiring from AIMS?
No, nowhere, Amit. I'm still hunting for a job. So maybe by April 2nd week, I'll be sure where I'll be. As of now, I have not joined anywhere.
Okay, ma'am. So AIMS will definitely be missing you, the genetics department for sure. And thank you, Dr. Ambika and
Thank
Dr.
you.
Anchal, for the wonderful talk. I request you both to please make some key points or key slides which we can circulate to our NNF members who were not able to attend it. With your name and qualification, we would send it. So that would as a PDF format. If we can do that, then a lot of people will gain from this wonderful talk as well.
Thank you so much.
Thank you, ma'am.
Thank you. Thank you.
Thank you, Dr. Sanjay.
Thank you.
Thank you, Dr. Manoj.